Hey, this is part 2 of the series regarding some of the ideas and concepts for preparation for ACL. So some of the strategies for training and rehab that we can get after when there is an opportunity to train before having ACL surgery. So one of the concepts that's crucial for any type of knee health or performance would be health and performance of the ankle and all of the relevant foot joints that go along with what we generally call the ankle. Now, I think it's very, very common to appreciate that limitations in dorsiflexion can affect the knee. How that individual compensates for a lack of dorsiflexion can lead to some significant anterior knee load. It can certainly also compensate with increased valgus and tibial rotation. Now, sometimes that tibial rotation is either made very, very easy and difficult to control, easy to happen, difficult to control, but also it can be mitigating it, is the function of the navicular bone. Okay, so the navicular bone, is a bone in the foot that it's south. I typically use words that everybody understands. Distal, inferior to the talus, and then superior or one north of the first cuneiform. So if you start here in the first ray and you come up, and unless there's a big Barney Rubble hamburger foot, the first joint that you come upon, the first little dip, that's the first cuneiform. Then the next dip that comes up, you're into the navicular. If you come from the top, the talus, and then the first architectural cutout, if you will, is the navicular. Okay, so the navicular is a major player in how the foot moves in all different planes. Now, this is not the only bone that's important. Every bone is important. Navicular, cuneiform 1, 2, 3, cuboid. Certainly the subtalar joint, where the calcaneus and the talus is a very unique triplanar joint. I think it was around last summer we were in a rehab Zoom with several other pretty qualified therapists, and one therapist felt that subtalar joint was crucial, and it certainly is. He felt that almost every ACL he saw, there was some type of subtalar joint issue. Not really buying that, every single one. You wrote all these down? I don't think so. That being said, it doesn't minimize the idea, the concept of the subtalar joint. But remember as well, if we have a day late, dollar short, since we're talking about ACL surgeries, but if we can create connective tissue improvements in the hypertrophy of the ACL by squatting below 90 degrees, I don't care. I think I said this on that there. I don't care how much subtalar motion or ankle mobility you have, you will show up to that dance with any degree of robustness in the ACL. Any given load is less apt to tear the ligament. So it doesn't mean that ankle mobility is not important. It doesn't mean that it's the most important. Everything is connected, everything matters. But when this navicular bone and the joint that is adjacent to the talus, as well as the first cuneiform, we have an opportunity to evaluate that. So what we'll do here, we're basically going to call the navicular right there here on this particular foot, and we're going to take the inside hand and kind of take a pincer grip on that bone. Okay, now what we're trying to do is take a PA glide and or some sort of rotary motion. There is no objective measure to how this thing moves. It's not like we're going to measure with a goniometer, and I don't know what good is. Now, we can certainly look at the other side, but they both might be the same. We may not see that there's a significant asymmetry, that if we think that this one doesn't move well, that you can tell, in my mind. I don't know what good or great is, but I know what bad is. And if I'm on this bone and I am putting my weight over top and being able to move, you can see that there's action. My other hand takes a larger pincer grip to stabilize the talus. Now, I might be moving 1, 2, 3 bones, maybe even 4, 5. But if they're moving from where my fingers are stabilizing at the navicular, I should have an idea of, is that bone moving? Okay? That's what we're after here. So can I get action where I think my fingers are on the navicular, a little bit south, talus, navicular, and here, okay? So I'm giving more of an AP approach, and it winds up morphing into something that's curvilinear. Does it move, or is it literally jammed where you can't get any kind of motion? Wiggle around, change the hand position. Now, in the grand scheme of things, what I'm showing here is completely out of context. If someone has great dorsiflexion and has ideal foot mechanics on however you choose to evaluate that, I'm not sure why you'd be here. But what I am suggesting is that you don't see a lot of people, number one, talking about, much less actually looking at these individual bones. So what I just gave you here was a quick way to evaluate if navicular is a part of this inefficient mechanical situation that contributed to the ACL. So now remember, we're preparing. This could certainly happen early on, after the surgery as well, in terms of maybe while they're doing some kind of passive, game ready or something like that. While there, then we can mobilize the foot. We certainly should be looking at right versus left. But again, I don't know what good or great is, but I do know what not good is when it doesn't move at all. And that type of wiggling technique that maybe you could call it something very similar to a grade 2 Maitland type of approach, or a grade 3 Maitland. Grade 2 you'd be doing with pain. This is not necessarily painful, so let's call it a grade 3, where you're just trying to find some end ranges. Now in this case, we would always be looking at talocrural, posterior and anterior. We'd look at cuboid, we'd look at the 3 cuneiforms, and we'd look at the first ray. I'm just showing you navicular, okay? Now, if for some reason the navicular is not moving, you can go in and try to just wiggle it. Now, I don't find that trying to gain something that doesn't exist in the first place is usually very successful. You can try. I don't think you're hurting the person. Getting some tactile approach might provide some type of neuroceptive input, and all of a sudden it starts to move. I don't think that's impossible. You didn't mobilize, you didn't change the quality of the tissue. You touching and moving around just created a neurological environment that allowed the joint to express what was already there, but there was some type of neurological environment, whether it's from the ACL related to it or not. That can happen. Okay, but the other approach to mobilizing this would be use a pumping technique, where if we scoot up a little bit where the knee is bent and the foot is flat, okay, and here, okay, so now my hands are underneath the foot. Now, this is a series of osteopathic sequences where if we can try to create subtle change in the joint architecture where fluid can re-enter the joint, we have to assume that that joint system doesn't have tensegrity, and it will not react as efficiently during foot mechanics in gait or associated with triple flexion, triple extension with the knee. Okay, so if I have this grip under and my thumbs come on top of the navicular, we have a multi-pronged process that is both active and passive. So the patient is absolutely participating, and they can participate as much as they want. The foot does relatively need to be flat. We might not be able to use this particular treatment approach if the knee can't get into flexion. So now, 2 hands under, 2 thumbs on top. The patient is going to be asked to dorsiflex, and I'm going to let them do it because that's the motion. The instructions are, you will take a breath in. Now, if you take a breath in, maybe we would have already coached the ideal breathing pattern, which is creating intra-abdominal pressure in a complete circumferential pattern, meaning the belly button goes down and forwards, we are getting lateral expansion and posterior expansion. That being said, the dorsiflexion that you're going to block isometrically is to create an isometric contraction lasts as long as one breath. Okay, so at that point we are putting pressure. Now it's contract and breathe in, and then relax and breathe out, but you don't relax, and then relax, and that's one cycle. So now it's you go, and then you relax, and then I relax. It's you go, it's I go, and relax. Okay? Now really what we're trying to do in terms of the name of the technique is pump fluid. So now if I'm creating pressure at the navicular, I'm squeezing the water balloon. So now the patient breathes, which now puts contracture through the pelvic floor and the diaphragm. The patient will contract and now begin to contract vasculature in the ventral portion of the foot. Then they relax, but I keep the pressure and then I relax. So it's squeeze, 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 and in an effort, push fluid through the body. Now, if we think we're creating any motion at the joint, then we believe that fluid will enter into the joint, and then you go back and check the navicular. Now, there's a deeper discussion here on what pumping is and what it isn't, but if we're looking to push fluid, we're attacking a lot of key areas where the vasculature can be compressed and then let go. So vessels that feed here from a venous route will go up the inside of the knee, go out the back, go up the side of the leg, go through the pelvic floor, go through the diaphragm, and then feed back through the heart. So if we can create pressurizations at each of these areas and then let them go, we may find that the joint can move. Now, I don't think it's a soft tissue technique. The soft tissue would have already had the extensibility. It didn't have the hydration. You add the hydration, it can now demonstrate what it could do before, because I would insist that any technique that is creating a dramatic change, it can't possibly be a frank change in the tissue. It had to be something more neurological or something that allowed the joint to express what it already could do. So then we come back. Remember, if we come up from the bottom, joint, now I'm in the first ray, joint, now I'm in the first cuneiform, joint, now I'm at the navicular, okay, and I'm going to wiggle up and down, and sometimes that pumping technique for the navicular can be very effective in getting it to move. What we would expect to see is some change in closed chain dorsiflexion and or whatever you're doing to measure foot mechanics in terms of maybe it's a pressure insole, maybe it's a force plate in jumping, etc., etc. But again, we're taking advantage of a period of time. Maybe as the knee recovers, maybe if you're doing 2-a-days, whatever it may be, addressing navicular can be a very effective component to any lower body rehabilitation.